Okay, so today we'll be doing surgery part one. So we are basically going to go through about 15 stations. So shall we start? So this is our station one. So and it goes saying that the woman was pushed accidentally by her friend towards boiling water 3 hours ago. She weighs 20 kg. Total body surface area of the burns were 14%. Then question one is saying measure the degree of her burns. Then option 2, calculate the total fluids she will receive using Pipeline's formula. Then question 3, mention the Jacksonian zones of her bends. Then question 4, explain the pathophysiology of shock in bends. Then last question, what is the management of bends at first contact with patient? So the degree of this patient's bends, as you can see, they are blisters. So these are second degree bends. Then calculate the total fluids using Pipeline's formula. So Pipeline's formula is equal to total body surface area times the body weight times 4 mils, which which we have been given. So the total body surface area is 14%, the body weight is 20, then the upper limit for this calculation is 4. So that's the 4, that's where the 4 is coming from. So if you multiply this, you are going to get 1,120 mils. Then we have just been told to calculate the total. So this is the total. So we haven't been told to say how we give. So we are done for this one. Then mention the Jacksonian zones. So the Jacksonian zones, we have the zone of coagulation, or it's also called zone of necrosis. Then we have the zone of stasis and zone of hyperemia. Then for shock, they explain the pathophysiology of shock in burns. So shock is due to, there are two hypotheses has been given. So one reason is that it is due to hypovolemia, which is caused by either fluid loss as a result of increased capillary permeability. So when there's increased capillary permeability, there will be extravasation of fluids. So that's one of the reasons. And this same increased capillary permeability due to SIRIs can lead to renal failure and systemic inflammatory response syndrome. Then the other reason why there is shock is due to the same inflammatory response, which causes the release of inflammatory mediators such as cytokines, which leads to vasodilatation in bent areas. This is also one of the other reasons. Then question 5 is saying what the management of bends at first contact with the patient. So this is a rough management. So make sure you remember your ABCs. So this is trying just to help you remember. So what we are going to do is we're going to cannulate, we're going to catheterize the patient, we're going to initiate the fluid replacement, we're going to wash the bent surface. So make sure you keep warm, you keep the patient warm, you give analgesia if the patient, especially if they are in pain or if they are complaining of pain. Then the last part is for admitting. So you have to look at the total body surface area. So just as you haven't been given, but so you can't assume anything because the 20 kg can either be an adolescent, can either be a child. So you don't have to assume. So if but it was manned. So if if you are the one who is seeing this patient, you have to know the admission criteria. So if they reach the admission criteria, then you also have to admit. Then this is the part where you wrap the patient or you cover the bent surface. So you can either cover the bent surface depending on what's available at your facility. So for example, this is just one of the examples. You can also wrap the bent surface in plastic, and then you can also add some honey if indicated as well. Yeah. So this it's not only done in all facilities, but in some is done. So just have to use one which is available at the facility where you are working from. So this is station 1 done. Then station 2 is saying a 47 years male with a 2 months history of rectal bleeding every time he opens bowels comes to the clinic. So question 1, describe what you see on the image. To Max, what is the definitive diagnosis, and how is the condition named in 2 graded? Then mention 2 surgical managements of the above diagnosis. So as you can see, it's even written here, but okay, there is this one, this perianal growth, and this which is internal, and this perianal growth which is this is an anal growth which is internal, like I said. Then this is a perianal growth. So, and it's even written here, internal hemorrhoid. So I think that was one of the pointers, maybe, if you still didn't know what these were. So question 1, describe what you see on the image. So since there are 2, are going to say there is one, the perianal growth, which is outside, the one which is outside. Then there is also one which is the growth in the anus, which is coming from the dentate line and going below it, as you can see. So if this is the dentate line, this is coming from above and going below it. Then what is the definitive diagnosis? So we have internal and an external one. So these are called mixed hemorrhoids. So how do you classify hemorrhoids? So hemorrhoids are graded or classified into graded from grade 1 to grade 4. So you have grade 1, which is the hemorrhoids or pus, they bleed but does not prolapse. That's grade 1. Then grade 2, pus prolapse when defecating but goes back spontaneously. And then that's grade 2. Then grade 3, pus prolapse when defecating but needs manual help to go back inside. So they need manual help to go back inside when defecating after they prolapse. That's grade 3. Then grade 4, pus are permanently prolapsed. So that's the last grade. So they mentioned 2 surgical managements. So surgical managements, we have a hemorrhoidectomy, which we have open or close. So for open, there are techniques named but usually there's the name of a person, a technique. But since they didn't want the exact techniques, they just want the surgical management. So hemorrhoidectomy itself, so it could be open or closed. Then we have stapled hemorrhoidectomy, which is an example of a closed one. But then stapled hemorrhoidectomy, there is also it can also be called procedure for prolapse and hemorrhoids, so abbreviated as PPH. Then there's also another one called hemorrhoidal artery ligation. So hemorrhoidal artery ligation and rectoanal repair, abbreviated as HALRAR. Then again, there's also another one where they don't do rectoanal repair, they just do hemorrhoidal artery ligation. So it's then that one is abbreviated as HAL alone without the RAR. So it can just be hemorrhoidal artery ligation alone or hemorrhoidal artery ligation and rectoanal repair. Then we have laser hemorrhoidectomy. Then of course these are not the only ones. So these are just some what I managed to put here. Okay. So station 3. This is the back of a 34 years woman. So what is your spot diagnosis? So what is your spot diagnosis? So mention the phases of wound healing. What 2 medicines are used in the medical management of the above condition? Mention 2 surgical management of this condition. So as you can see, these things which are growing on the woman's back and also on this hand as well. So the question is, what is the spot diagnosis? Okay, and the woman is 34, she's black. Okay, so these are massive keloids. This has the spot diagnosis. Then phases of wound healing. So phases of wound healing, we have HIPR, then which stands in for hemostasis, inflammation, proliferation, and also have remodeling and maturation. So this is the first one, but then remodeling is also called maturation. So these are the phases of wound healing. Then also just take note of the they can ask you phases, then they can even just change to more like stages of wound healing or something. Yeah, but they are not much different, but they have the same things. So you just have to take note of the stages as well. But these are the phases of wound healing. So hemostasis, inflammation, proliferation, and maturation or remodeling. Then what two medicines are used in the medical management of the above patient, of the above condition? So we have triamcinolone, we have bleomycin, verapamil, and they are a lot. So these are just the ones I managed to write. But the most common used one is triamcinolone, which is we use it for intraregional corticosteroid injection. Then mention two surgical management of this condition. So surgical, we have surgical excision and skin grafting. We also have intraregional excision. Then where I was doing my research, they indicated laser therapy and cryotherapy as surgical management. Then, if you think how we know what surgical is and what medical is, so sometimes we end up thinking if surgical is has to involve you cutting, then medical has to involve you giving medicine or something. So you can drop in the comment section. This question I added to say, can laser therapy and cryotherapy be considered medical or surgical? So just drop what you think in the comment box, comment in the comment section, so that we find out together which part they fall, these two. Because if they fall on surgical, then we have to put them here. All right, we are done for that part. Then these are some of the knowledge tips to be murdered by. So there are popular questions on the words where they ask you to differentiate hypertrophic scars and keloids. So hypertrophic scars, they remain within the confines of the wound, whilst keloid scars, they project beyond the original wound margins. Then hypertrophic scars, again, they regress over a period of time, whilst keloids do not regress over time. Then hypertrophic scars improves with surgical intervention. Then keloids outcomes worse with surgical intervention. Then hypertrophic scars has no association with skin color, whilst these are associated in individuals with a darker skin tone. Oh, yes, black Africans. Then that's the most race which is affected. Then we have this other part develops soon after injury, then may develop several months after initial injury. Does not form spontaneously, may form spontaneously without prior injury. Then develop in wound locations under eye tension, or such as shoulders, neck, knees, and ankles. Then these occur anywhere on the body, but predominantly on earlobes, upper arms, sternum, and deltoids. Then this is also another table uh, differentiating the two. So you have to pause the video and you go through on your own. So you can just pause the video, you go through. Okay, so let's go to the next station 4. So the patient weighs 10 kg and has a left femur fracture, and so suppose a man station, so that should have been uh, a patient on a traction. So questions: what treatment modality is being used in this patient? What counter weight will be used on this patient, and by how many centimeters will the bed be elevated? Question 3: name two orthopedic and two non-orthopedic indications for treatment modality named in 1. Then, what are the complications of skin traction? Okay, so what treatment modality is being used in this patient? So they're just asking for the treatment modality. So the treatment modality is a skin traction. So this is a skin traction. Then what counter weight will be used? So for the counterweight, we are going to, since this is a skin traction, we're going to use 1 out of 10 of the patient's body weight, which is 1 out of 10 times 10 kg, which is giving us 1 kg. That's the counterweight. Then by how many centimeters will be the bed be elevated. So bed elevation, there is a formula for bed elevation, which is 4 centimeter multiplied by the kg of the patient of the kg of weight placed. So of weight placed. So which is the 1 kg. So 4 centimeter for every kg we have. So we have just have 1 kg. So we are going to elevate the bed just by 4 centimeters, since we do 4 centimeters by every kg, by every kg of the weight placed. Okay, which is the one. So here we have 1 kg for 1 centimeter. So 1 kg for 4 centimeters. So we are going to elevate the bed by 4 centimeters. And then name 2 orthopedics and 2 non-orthopedics. So orthopedics, we have hip dislocation, fracture of pelvis, fracture of femur, disc prolapse. We have osteomyelitis, septic arthritis, dislocation of sacrum, and of course these are not the only ones. Then we have non-orthopedics, which include periannual or gluteal bends. We also have perineal. Oh, sorry, this was perineal bends. We also have perineal or gluteal abscesses. Or we have hernias such as obturator and umbilical hernias. Then we have rectal prolapse. We have contractures, skeletal swelling, such as congenital hydrocele. We also have non-thrombosed hemorrhoids, and of course spinal bifida. Then last question is saying, what are the complications of skin traction? So complications of skin traction, we have skin avulsions, allergic reaction to strapping, compartment syndrome, joint stiffness, gangrene or ischemia to distal limb, and also most commonly hypostatic pneumonia. That's one of the complications. So we are done for this station. This is the station 5. So a 60-year-old man presents to OPD with complaints of pain on swallowing for for 2 months. So this is the man, and he has some we have this mass. Then question 1, describe what you see. What is your spot diagnosis? What how would you investigate this condition? Mention 3 surgical procedures that can be done on this mass. So describe what you see. So we're just going to describe what we are going to see. So this is there's a large mass on the anterior neck. So there's a large mass on the anterior part of the neck. Then what is your spot diagnosis? So this is the spot diagnosis for this is a thyroid goiter. That's a spot diagnosis. Then how would you investigate this condition? So we can do our serum T3, which is thyronine. Sorry, it's not supposed to be thyrotomy. So we also have T4, which is thyroxine. We also have TSH, which is thyroid stimulating hormone. Then you also can also do a neck ultrasound or the same thyroid goiter. Then you can also do a neck X-ray, a fine needle aspiration and cytology, full blood count, and peroxidase antibodies, and thyroid antibodies as well. Then mention 3 surgical procedures which can be done. So we can do a thyroid lobectomy, that's one, subtotal thyroidectomy, and total thyroidectomy. So that's the procedures can be done. So we are done for this part. Then there's this one. She's saying so this patient was stabbed by a knife in the abdomen whilst fighting. So he has severe abdominal pain, but now comes to A&D, from which the LMO orders a chest X-ray below. So this is chest X-ray. So question 1, describe the pathognomonic feature shown on the X-ray. Question 2, what is the spot diagnosis? Question 3, outline 2 further investigations you would order. And question 4, how would you prepare this patient for theater? So describe the pathognomonic feature. So as you can see, the patient was stabbed in the chest. He was stabbed, he has severe abdominal pain, and was stabbed by a knife in the abdomen whilst fighting. So the abdomen is big, so I haven't been told where exactly. But if you can see here, there is this this dark stuff. So this is called the air under the diaphragm. So that's the pathognomonic feature. So this is the under the diaphragm or subdiaphragmatic free gas. Then what is your spot diagnosis? So since you haven't been told much of the details, so since you're stabbed, so in a knife, if someone stabbed you with a knife, and you are not sure what uh, any perforation or to which specific organs, you haven't done any investigations to differentiate the organs perforated or any injured vessels and the like. So the diagnosis is this is a penetrating abdominal trauma, which is also called PAT. Then what outside into further investigations you can order. So you can do a fast, or they can also do a plain abdominal X-ray, CT abdominal scan, MRI. Then you can also do a FBC cross match, urea and electrolytes. But these are not the only ones, of course. Then how do you prepare this patient for theater? So preparation for theater, of course, you have to start from the first stop. You have to confirm the patient's details, explain the procedure, gain signed consent, cannulate, catheterize, correct blood for FBC cross match. Then you also have to keep the patient new per oral. Then you also NGT if need arise. Also advise on bathing, remove patient's accessories. So if they have any jewelries, any glasses, any rings, also if they have any dentures, you have to remove them, and also makeup. But since this patient was a man, so unless otherwise, but yeah. So if it's a woman, you have to make sure the makeup is removed, and you also have to preload the patient with fluids. So you can give them fluids for an NSO ringers lactate. So we are done for this question. Next question. So this woman came in OPD with history of 2 months old wound on the foot. So question one, describe what you see in the image below. Then what are the risk factors for developing the above condition? Define amputation, indications of amputation, mention 5 types of amputation. So describe what you see. So let's describe what you see. So in description of what you see, you have to use your own terminologies, as in what you yourself can describe. So as you can see on the right toe here, it is dark. It is dark in there. There is this, and this part is swollen, and it is reddish, as you can see. So this is how I would describe it, but you can also describe it in your own words. Yeah, there's no limitation to what you can describe. As long as you can see it, you can describe it. Okay. So what are the risk factors for developing the above condition? So you can some of these factors is wearing tight shoes, being diabetic, being hypertensive, and also individuals who are immunocompromised is a risk factor as well. But of course, there are also other risk factors. Then define amputation. So amputation is a removal or loss of an appendage. So that's the definition for amputation, and it's 1 mark. We are done. So indications of amputations, we have the 4Ds. So dead loss or dying, and also diminutions. But when you ask the indications of amputation, you don't have to end on dead. These are just mnemonic to help you remember. So dead is for dry gangrene, Buerger's disease. Then for deadly or dangerous, we have wet gangrene and necrotizing fasciitis. Then dead loss or dying, we have crash injuries or severe lacerations or severe fractures. We also have diminutions for polydactyly, severe impacted gait, and gait is just the manner of walking. You didn't know that one. Yeah. Then mention the 5 types of amputation. So there are a lot, so I'm just going to mention some. So you have raised amputation, seams amputation, below the knee amputation, through knee disarticulation, above knee amputation. So we are done with the 5 types on this station. So this patient was diagnosed with BOO, so it's blood outlet obstruction. Question 1, what can you see? What are the different types? What are the indications? What is the absolute contraindication? So what can you see here? So this is a suprapubic cystostomy, and here the puncture, you can see there's a puncture site here. So this is a suprapubic cystostomy. and this is a two-way catheter in situ. So you can say a suprapubic cystostomy with a two-way suprapubic catheter in situ. Then what are the different types of this? So I'm sure they were asking about the different types of suprapubic cystostomy, because we might end up saying the different types of catheters, but there's questions for suprapubic cystostomy. So we have open cystostomy and closed cystostomy. What are the indications? So indications, we have retention of urine when transurethral catheterization has failed, rupture of the urethra, urethral-cutaneous fistula, can also have periurethral abscess, extravasation of urine, chronic retention in neurogenic bladder, can also have urethral stricture as well. So the way I used to remember when I was a student, I used to say, when I've been taught to ask, I just have to remember pay. I just have to start with pay. So I will mention periurethral stricture, periurethral abscess, periurethral cutaneous fistula, periurethral rupture. So that's more like, I just have to remember, I have to start with pay. Then of course there's this one which was used to remember, when retention of urine when transurethral catheterization has failed. So what is the absolute contraindication? So absolute contraindication is bladder carcinoma. Then there is some additional information I want to share with you. So this is some additional information on the contraindication of suprapubic cystostomy. So we have relative contraindications and absolute. So that question asked about absolute. So percutaneous suprapubic cystostomy is absolutely contraindicated in the following circumstances. So one, when the bladder is not distended, or is not easily palpable, or cannot be localized with ultrasonographic assistance, or the patient has a history of bladder carcinoma. So that's why we put it on the absolute contraindication. Then the relative contraindication include coagulopathy, previous lower abdominal or pelvic surgery. We also have pelvic cancer with or without a history of irradiation. Then we also have placement of orthopedic hardware for pelvic fracture repair. We also have, although some reports suggest that suprapubic tubes leading to infection of hardware is a relatively rare complication. Also the other one is if percutaneous placement is contraindicated and open surgery approach to suprapubic cystostomy is necessary to provide the appropriate dissection through adhesions. Also avoid bladder injury. So it's more like just an addition to the point which is above, but these are some of the relative and absolute contraindications. Okay, so station 9, she came to OPD with an ulcer on the breast for 4 months. So describe what you see, write 3 differentials, state the method of confirmatory, then state operative and non-operative therapies for breast retention, 3 marks. So as you can see here, so the answers for this question. So this is a massive or deep ulceration. As you can see here on the upper. This is the upper part. This is the upper outer quadrant of the left breast. Then write 3 differentials. So we have breast carcinoma, breast tuberculosis, breast abscess, and you also have a non-eating breast ulcer. So why breast abscess? So it's good of, you know how breast abscesses are when they reach a point of someone perforating them, maybe so to say. Then the method of confirmatory, we have excision biopsy, core needle biopsy, fine needle aspiration, and cytology. These are some of the methods of confirmatory. Then for operative, for operative and non-operative. So for operative, we have radical mastectomy, total mastectomy, subtotal mastectomy, modified radical mastectomy. Then for non-operative, we have chemotherapy, radiotherapy, and also meds such as tamoxifen. So these are some of the operative and non-operative. Then let's go to station 10. So this was supposed demand station. So there should have been a patient who was hit by a brick in the abdomen 4 days later. They were hit in the abdomen, and 4 days later they developed severe abdominal pain. So just imagine yourself that you are in front of a patient and this happened to a patient. So these are some of the questions which were asked. So what is the relevant history would you take? What is your what is your diagnosis? And also define branch abdominal trauma. What definitive investigation would you order? And what does the letters first stand for? And what surgical procedure is done for? But how would you prepare a patient for OT, which we did the, last in the previous questions. Then what relevant history you can take. So mechanism of injury, you have to understand like they were hit by a brick, like but how big was the brick? So what was the distance was the brick thrown since they were hit? So I have to know exactly, was it thrown at them or is the patient holding it and he just hit them there and then? Also you have to know the site exactly. Where exactly in the abdomen? So we're just been given abdomen, but where exactly? Is the patient able to pass bowels? Are there any blood in stools? What about vomiting, etc.? So these are just some of the questions, the relevant questions we can ask. Then what is your diagnosis? So the diagnosis here is branch abdominal trauma or BAT. Then define branch abdominal trauma. So BAT is the injury to the abdomen by a blunt object with no any notable openings on the anterior abdominal wall. So that's the definition. So what investigations? So we can do a fast. So a good thing we were even asked to say what does the letters fast stand for. So fast stands for a focused assessment with sonography in trauma. That's fast. Then what surgical procedure is done on this patient? So the surgical procedure done on this patient is a exploratory apparatus. So that's where we go to find out exactly what's wrong with the patient. Then how would you prepare this patient for OT? So the same things we did on that previous question for part. So that's the confirm the patient's details, explain the procedure, gain signed consent, candidate catheterize, correct blood for FBC, cross match, keep the patient new peoro, NDT if need arise, the same things we did, and the period fluid, don't forgetting about it. Okay, so let's move. Station 11. So this is station 11. So the X-ray below is of a 27-year-old male who's opening bowels but has had a chronic abdominal pain on and off for 3 weeks. What is the spot diagnosis? Type of X-ray is this? How will you confirm your diagnosis? Mention 4 treatment modalities for your diagnosis. So what is the diagnosis? So if you are not paying attention to this X-ray, you might think maybe it is intestinal obstruction or something. But again, the patient is opening bowel, so again you get confused. Or maybe you think maybe this is a partial obstruction. But if you can see this part, you can see a white opacity here. So and this is where you have the retrospect, you have the kidneys. So spot diagnosis here, these are renal calculi. So these are renal calculi. That's where we have the kidneys. And then what type of X-ray is this? So this is a kidney, ureter, bladder, or a KUB X-ray. Then how will you confirm your diagnosis? So I confirm the diagnosis by taking a lateral view. So if you take a lateral view, so how can we differentiate what we're going to find? So if they are gallstones, they have to lie anterior to the vertebral body, and if they are kidney stones, they have to lie posterior to the vertebral body, then or overlaps the vertebral body. Then confirmation, then the absolute confirmation will be by an ultrasonograph. They mention 4 treatment modalities for your diagnosis for renal calculi. So we have ureteroscopy, so which can be used to remove or break up the fragments of stones located in the lower third of the ureter. We also have lithotripsy, this procedure which is effective for stones in the kidney for upper ureter. Then we have percutaneous nephrostoisotomy, this is PCN. Then we also have open surgery, and of course there are others, but these are some of the things I managed to put here. So we are done with this station. So finally, something you see on the words and something practical. So what is this? What are the indications and what are the complications? So the this is an endotracheal tube. The indications: you can use it to facilitate artificial ventilation, facilitate surgery around the face or neck, and protect lungs if pulmonary if risk of pulmonary aspiration. Then you can also use it in cardiac arrest, serious head injury, inhalation of burns. Complications: we have early and late. So early, we have accidental esophageal intubation, loss of airway control, accidental intubation of the main bronchus or right. Then we also have trauma to larynx, trachea, or teeth. You can also have aspiration of vomitus during intubation. So laryngeal tracheal perforation as well. Then late complications, we have disconnection or a blockage of the tube. You can have infection, delayed tubal stenosis due to prolonged intubation. Those are some of the complications for this. So make sure I also practice to speak out the answers, because with the introduction of lex, so make sure you are very uh, adapted to speaking the answers rather than writing them down. Okay, so this is an X-ray of the patient who was hit by a bicycle and developed right hand pain and unable to lift they were unable to lift it above the head. Describe what you see. What is your what is your diagnosis? List three maneuvers for the treatment of your diagnosis, and list the complications for your diagnosis above. So describe what you see. So you can see here there is a dislodged right humeral bone from its socket. You can say that the humerus is displaced medially or and inferiorly, or you can also say the humeral edge and outline of the glenoid cavity are incongruent. But I'm sure the easiest thing you can say is just that the the humeral bone is dislodged from its socket. Then what is your diagnosis? So as you can see, this is in anterior. So the diagnosis is anterior shoulder dislocation. You can see the rotation of the dislodged humerus. Okay, these three maneuvers. So maneuvers, they are a lot. So we have traction, counter traction, we have scapular manipulation, we have external rotation, we have steamstone technique, we have Milch techniques, Paso technique, and Davo technique. So there are a lot. You can just pick three from any of these. Then complications of this diagnosis: we have fracture or neck of the humerus, brachial plexus injury, nerve injury, vesicular injury, rotator cuff tear, avulsions of glenoid labrum anterior. We can also have damage to the humeral head. We can also have fracture of greater tuberosity, axillary nerve palsy. We can also have arterial injury, which is very rare. So for you to actually make this to know if it's there, you have to check the radio pulse before deduction. Okay, so this is station 14. So this patient came in clinic to post OT. So okay, so describe what you see. What is a colostomy? Mention two types of colostomy. What are the complications of colostomy? So okay, so describe what you see. So there is a stoma on the right iliac fossa. So this is the right iliac fossa. So there is this stoma here. Then the question is, what is a stoma? What is a colostomy? So a colostomy is an artificial opening made between the large intestines and the anterior abdominal wall for excretion of feces. Then mention two types of colostomy. So the two types of colostomy we have permanent colostomy and the temporal colostomy. So these are just some of the examples I managed to put. So an example of a permanent colostomy is an end colostomy. Example of a temporal, we have loop, Hartmann, double barrel, and spectacle. Then complications of colostomy, we have general and specific. So general, we have the ones which are related to the underlying disease. We have stomach diarrhea, and then we have the ones which are related to water and electrolyte imbalances. We have hypokalemia being the most commonest and the most important consequences. So I have nutritional disorders, stones, so it can lead to both gallstones and renal stones, and the increase in frequency following an ileostomy. So an ileostomy is one which has these these stones as a consequence. Then we also lead to psychosexual complications such as impotence or in men, or loss of libido. It can also lead to residual disease such as Crohn's and parastomal fistula. Then specific complications are ischemic gangrene, hemorrhage, retraction, prolapse or interception, parastomal hernia, stenosis, which leads to constipation. So this is an MCQ question where they ask you to say which one is not a recognized complication of a colostomy. So uh, constipation is not a complication of colostomy, but stenosis is the one which leads to constipation. So this is an MCQ question. So there is also skin excoriation and also fistula. So we are done with this question. So station 5, for this patient who is being managed for the type C spinal injury and developed these ulcers on the sacral region. So supposed to be manned. So define pressure ulcers, list the 4 common sites of pressure sores, then stage pressure sores according to the National Pressure Ulcer panel. Should be avoiding the A part, what it means. The management of pressure ulcers, then okay, so define pressure ulcers, the definition. So pressure ulcer is the damage or injury or break in the continuity to an area of skin or epithelial lining caused by constant pressure that results in venous obstruction. List the 4 common sites of pressure ulcers. So we have buttocks, sacral region, coccyx, elbow, shoulders, head sides such as the lateral aspects. So these are some of the common sites. So you can just pick in 4. Then staging, we have stage 1 to 4. So stage 1, we have intact skin with redness or non-branchable erythema. Stage 2, we have partial thickness, skin loss, and the ulcer extends down to the epidermis and or dermis. Then stage 3, we have the full thickness, skin loss, and the ulcer extends down to subcutaneous fat and fascia. Then stage 4, we have full thickness skin loss and tissue loss, and the ulcer extends down to muscle, bone, tendon, or joint capsule. Then management of pressure ulcers. So management of pressure ulcers. So you have to manage the pressure ulcers, not necessarily the patient. This one like this one. So, but since what we are going to say is basically what we can also do in this patient, so we can start. So with our returns and other forms of reduction of pressure. Then you can also do wound care, irrigation and daily wound cleaning, prophylaxis antibiotics, analgesia if patient complains of pain, nutrition support and other lifestyle modification to reduce factors affecting ulcer healing. You can also do a surgical intervention, usually per stage, and stage 3 or 4 lesions flap reconstruction may also be required. Then stage 1, 2, 3, 4 adequate. You can also do adequate debridement of necrotic and devitalized tissue can be necessary. So debridement can be necessary in these stages, all of them to be specific. Okay, so I think we are done with the questions. So thank you for watching, and make sure you check out the other videos we have posted on the platform. This is the end of our tutorial.